Good afternoon, everyone. Thank you for joining PHCA for today's webinar, RoP Phase 3, What We Know, What We Don't Know, and How to Prepare. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenters will address them at the end of the presentation. Today's webinar is being presented by Sara Rudow, Senior Director of Regulatory Services with AHCA, and Janet Snipes, Executive Director with Holly Heights Nursing Center. The webinar will provide an overview of the Phase 3 requirements of participation, the purpose and intent of these changes, and steps centers can take to prepare during a time of uncertainty and continual change as we await Phase 3 guidance from CMS. The webinar will further highlight current CMS priorities and the changes included in CMS's proposed rule on changes to promote efficiency and transparency in the requirements of participation. Finally, the presenters will provide information on AHCA tools and resources to assist you in implementing these requirements. I'll now turn the webinar over to Janet and Sara.
Hi, thanks, Wendy. This is Janet Snipes, and I work in a nursing center in Denver, Colorado. So we began working on these things about a year ago, probably like most of you. So today, our objectives are to, so hopefully you'll recognize key changes to the federal requirements that go into effect November 28th. So that's Thanksgiving Day, and it's only 23 days away. And then we're hoping that you will have some actions to take back to your own center to prepare for these Phase 3 guidelines while we await the additional CMS guidance and their resources. And then we hope you will also understand how current CMS priorities and the pending rule revising the ROPs impact your preparation. So we're going to go through the presentation, and then we'll save time for questions at the end. As I go through, I'm going to share with you some of the areas that I've implemented successfully, and I'm sure that many of you have success stories as well. I think the key is to keep it as simple as possible and implement through systems that are already in place in your own centers. So these are the Phase 3 requirements that are new, and they're the significant requirements that CMS felt required more time and broader systems to implement. So we'll go through each of these in detail as we move along. The requirements go into effect on November 28th, even though CMS has not issued guidance timely. However, CMS recognizes that it is difficult to enforce the requirements without the interpretive guidance, and we don't expect the surveyors to go into depth on the requirements. However, you do need to be prepared to show what you're doing to implement the Phase 3 requirements with good faith effort. And remember that surveyors are expected to survey the regulations, so specific requirements explicitly outlined in the regs should be implemented. So the first one is trauma-informed care. At its core, trauma-informed care is a facet of person-centered care. So the key step you need to take to implement this requirement is think about how you bring the concepts of trauma-informed care into the person-centered care planning processes in your own center. An easy way that we found to implement these was we have always had a pre-admission sheet where we ask about preferences such as bedtimes, types of baths, that type of thing, their normal routines and preferences. So we just adapted the questionnaire we were already using to ask about any traumatic events that they've had in their lives and any cultural preferences. And then we incorporate the information into our routine process. Trauma-informed care, F699 is the primary tag that they're going to cite for trauma-informed care. And so we must ensure that our residents who are trauma survivors receive culturally competent trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. So to operationalize what we have done is we discuss the trauma or the cultural preferences in our daily stand-up meeting, and then we ask the unit manager to incorporate that information into huddles on the day of admission so that the staff are informed that are on the unit. Our staff development coordinator is also in that meeting, and so we ask her to assure that our lesson plan includes the appropriate training and competencies for either the trauma-informed care or around their cultural preferences. And then the care planning team is in there as well, and we ask them to identify the triggers that would prevent any re-traumatization and then move forward with care planning that. So the care plan, F656, will need to identify what it is you are doing to mitigate the triggers and make sure that we are meeting their cultural preferences. The behavioral health regulations at 740 through F744 state that each resident must receive and the facility must provide the necessary behavioral health care and services to attain or maintain the highest practicable level physical, mental, and psychosocial well-being. This includes providing treatment and services for the residents with mental and psychosocial disorders that was a part of Phase 2 guidance. And then Phase 3 adds appropriate treatment and services for residents with history of trauma and PTSD. These competencies and skill sets include implementing the non-pharmacological interventions as well. You'll want to keep track of the different traumatic events and evaluate whether you have the competencies and skill sets necessary. A good place to start is with getting to know the whole person, their life history, and what their triggers may be. So some overall survey expectations would be that the services are meeting their behavioral health needs, that the residents receive person-centered care and individualized treatment and services to meet their assessed needs, and that, of course, we evaluate the effectiveness and revisit on change of condition. Their goals are individualized, and their interventions are related to their diagnosed conditions and their history. So we have found that most families and or the residents themselves are helpful in identifying their own triggers and interventions. We in our facility take care of a lot of veterans, and we have found that loud noises and startling really impacts them. So we tried very hard to, for instance, if we're going to have a jackhammer in the parking lot or something, make sure everyone is aware that this is going on and be there to provide support and services to them. Here's some questions you might want to ask your staff about trauma-informed care. Don't forget, though, that the facility assessment must also address the types of staff needed to meet that you're going to need to meet the needs. Considerations in your facility assessment would be if you have residents with dementia, mental disorders, intellectual or developmental disabilities, traumatic brain injury, substance abuse, that type of thing. The resident care plans identify the individual interventions, but your facility assessment identifies those that you have the capacity to care for. Moving on, we have the QAPI program. We've all been working toward a comprehensive QAPI program for years, and this year the rubber meets the road. The intent clearly identifies a data-driven approach with prioritization for your performance improvement projects in systemic action. The program must have these core elements as designed in the regulations. A design and scope that is able to address all systems of care and practices, including clinical care, quality of life, and resident choice. It must have a system for feedback, data collection, monitoring, including adverse events. Must take actions to improve performance and track your progress to each goal. Must be sustained and invested in by leadership and governing body, including changes in leadership. And the QAA committee must oversee the QAPI program, must develop and implement action plans, review the data collected under the program, and in Phase 3, it must include specifically the infection preventionist. In the proposed rule that was issued in July, CMS proposed some changes to the QAPI program. It gave greater provider flexibility in tailoring the QAPI program to the specific needs of the individual center, simplification of detailed prescriptive requirements related to the program elements, and it also stated, which we thought would be very helpful if it goes into effect, review of the QAPI documents should only occur at the end of survey after investigations into all other requirements are complete. There are numerous sections of the requirements that refer to the QAPI program, including setting priorities for high risk, high volume, and problem-prone areas, and tracking medical errors and adverse events to implement preventative action. We all know that you can't have numerous PIPs and be effective with all of them. So if in our center, we use a stoplight approach with red, yellow, and green. Red meaning that they're high volume, problem prone, and so we need to prioritize those, and green meaning those that may impact other areas that aren't quite as significant. The QAPI program oversight, F837, the guidance directs surveyors to request the names and contact information of the members of the governing body at their entrance to the facility. We have to have a system in place for routine reporting to the board and maintaining privilege protection of our QA documents. Instances of abuse and neglect must go through the QA&A committee in Phase 3. In my community, I track through QA the type of allegation, the residents involved, the staff involved, and the location of incidents. I hope that through doing this, I'm able to develop action plans that mitigate reoccurrence of like events, trying to be proactive in preventing abuse. Think about how you're going to keep and create documentation for QA. Summary pages versus detailed report of information discussed. You'll need to develop a system where information is segregated so that the facility can offer some level of evidence of compliance, if need be, without disclosing all the documentation. I think anyone who's been through multiple surveys always faces the moment where you have to look at your QAPI information and decide if it's better to disclose it or better to keep it to yourself. And so as you prepare your minutes, you'll want to look at that and see what will be helpful to share with them. Here are some key questions to ask the staff. We need to process for reporting QAPI activities, summaries to owner and board members, QAPI disclosure. We're going to be required to maintain documentation and demonstrate evidence of our ongoing QAPI program. And we also want to have language that addresses the need for the governing body or executive leadership to be accountable and responsible for the QAPI program. As I mentioned earlier, the infection preventionist must be a part of your QA program. So we must designate one or more individuals as the infection preventionist who are responsible for our facility's infection prevention and control program. The current requirements say they must work at least part-time at the facility and have specialized training. The infection control requirements are very extensive and significant. It continues to remain the top first or second citation across the country year over year. So efforts to improve infection control systems in your own center are vitally important. In the proposed rule issued in July, CMS proposed changing the requirement for infection preventionist from being a part-time employee of the facility to a person who has, quote, sufficient time at the facility to achieve the objectives of the infection prevention program. Those proposed changes are still pending and unlikely to be finalized before November 28th. So you want to ensure that you have a qualified IP in place who has received the necessary training and certification. Based on the proposed rule changes, we would not expect citations if your infection preventionist is working less than part-time in the facility. However, the surveyors may raise concerns if they find extensive infection control issues and connect those issues to the lack of adequate time in the facility by the infection preventionist. The infection preventionist participation in the Quality Assurance Committee, they must be a member of the committee, and then they must also report to the committee on the infection prevention and control program on a regular basis. So a very active member of that committee. Now we're going to move on to compliance and ethics. And most of you are doing most of this already. It's been a best practice for over 20 years. The Office of Inspector General developed resources back in 2000 and again in 2008 that outlined these best practices. They're a great resource to use while we await the interpretive guidance for Phase 3. AHCA also has a toolkit with a wealth of information. The current regs for organizations with 5 or more facilities include mandatory annual training, a designated compliance officer that reports directly to the governing body, and a compliance liaison at each facility. CMS has proposed to change this in the proposed rule. The annual review of compliance and ethics would be changed to a periodic review. And then also for organizations that operate 5 or more facilities, removal of requirements for the designated compliance officer, compliance liaison at each facility, and that training be conducted annually. Larger organizations are expected to have a program of appropriate complexity, were the words that they used. And the key is to have a program in place that meets all the elements outlined by the OIG. This is a key element of overall compliance and can be a great tool in your facility to ensure overall compliance with the regulations. F895. Here are some of the elements for F895 that I'll go into with a little bit more information. You'll want to take a look at your current program to assure it meets each element of the requirement. Here are some steps to take that you can develop a short in-service and some policies and procedures. Develop a tracking program for employees, contractors, and volunteers who complete the in-service. We've always had to do employees, and the contractors and volunteers are a little bit harder to track and trend. And here's some questions to ask your key staff. Training program. Our training program must be effective and include all the required elements, and it must be tied to our facility assessment. So there are 9 discrete required topic areas. 3 were required in Phase 1. 1 area was specific to in-service training for nurse aides, and 1 was relevant to all staff. So the training topics must include, but are not limited to, these are all the areas. I won't review each one, but they had some very specific language about effective communication and how our staff communicates with our residents. And then, of course, behavioral health, as we've already talked a little bit about. And then any other topics guided by your facility assessment. So you want to take a good look at your facility assessment, and you want to assure that you have training developed and competencies developed in the areas that cover your specific facility assessment. CNA training. There are 12 hours of in-service training for CNAs, and it's calculated from their hire date. I just had surveyed 3 weeks ago, and we had calculated everything for a calendar year, but we had to recalculate it during survey from their hire date. The new area addresses performance reviews. And so in our facility, we take the individual performance review and educate the CNA on the elements that were identified in their performance review. Then we also track and trend so that we can educate all CNAs on any trends we noticed in performance reviews. Again, some steps to take. And again, don't forget to include your contractors and volunteers in the required training, as well as any other competencies that pertain to their duties within your community. Here's some steps to take again. You want to do a gap analysis from your facility assessment for the resident characteristics and the treatment requirements, and ongoing monitoring of staff practices. It's one thing, as we all know, to do training, but how we determine the competencies, we must be out there on the floor and do the monitoring of the staff practices to assure that the competency is there. And here's some questions to ask the key staff. How are we doing the volunteers? How are we tracking the contractors? That type of thing. Call system. I'll breeze through the call system as it does not impact most facilities. But the intent of this requirement is that residents, when in their rooms, toilet and bathing areas, have a means of directly contacting caregivers. In the case of an existing centralized nursing station, this communication may be through audible or visual signals and may include wireless systems. In those cases in which a facility has moved to decentralized nurse care team work areas, the intent may be met through other electronic systems that provide direct communication from the resident to the caregiver. And here are some steps to take. If you don't have that call system, you'll want to be contacting some vendors while awaiting the guidance. So here's some resources for some strategies for survey and compliance. There's lots of resources out there, and AHCA has many resources as well. So don't invent the whole thing all over again. Try to use the resources that we have. And then know the trends. I don't know if you have accessed the QCore website yet, but CMS puts all the, each facilities across the nation, their deficiencies, and tracks and trends them, and it is an amazing, gives you a wealth of information. So I'd strongly recommend that you look at that when looking at the tracks and trends, see what deficiencies are being cited in your state. And with that, I'm going to turn it over to Sara.
Thank you, Janet. Bear with us for a moment, please, and we will get the slides turned over to Sara. One moment.
Hi, everyone. Can you see my screen?
Yes, we can.
Great. Thanks, Wendy. Thanks so much, Janet. And I'm going to pick up and talk a little bit more about the proposed rule that CMS released in July. Janet mentioned a couple key areas of Phase 3 that CMS proposed changes to, and kind of talked a little bit about how to handle that, given that we don't think the rule will be finalized before Phase 3 goes into effect, which we know creates some concern and some confusion out there. So we're trying to give you some tips to really help you proceed in this time of some uncertainty. As I'm sure you're aware, in July, CMS issued that proposed rule, and the goal really was to ease some of the administrative and paperwork burdens within the requirements of participation. And they touched upon different areas of the requirements, as well as some parts of the survey and enforcement process, like the IDR process, really trying to take away some of those excessively burdensome and really paperwork-oriented compliance to allow centers hopefully to focus even more on providing high-quality person-centered care. So this slide, just is for your reference, it lists all of the regulatory sections that did have proposed changes in the rule. So you can see there's quite a bit. I'm going to go over just a few highlights. As I said, Janet mentioned some of them. And if you'd like more detail, I encourage you to visit the AHCA and CalEd website, AHCA's educational platform, where we have a webinar that we recorded just after the rule was released over the summer that will give you even more detail if you'd like that information. And you can watch that recording on demand at any time. So one quick point about the grievance process under resident rights, CMS did propose a change to this section, really to add some changes for clarity and more flexibility for centers, removing the specific duties required of the grievance official, so sort of to alleviate some of those workforce concerns, removing some of the specificity that was required in the written grievance decisions, and also reducing the period of time that you have to maintain evidence demonstrating the results of all grievances. They took that down from 3 years down to 18 months so that it was encompassed within a particular survey cycle. On the admission transfer discharge side, those transfer discharge notices that have been such a source of challenging paperwork issues and some confusion as well from state to state and how to interpret it. CMS has taken a look at those transfer discharge notice requirements and has proposed that only discharge notices will only be required to be sent and copied to the long-term care ombudsman in situations where it's an involuntary transfer or discharge initiated by the facility, and excluding those transfers to an acute care facility when return is anticipated. So basically, that's something we've advocated for really from the time the rule was first issued. And we hope that this will lead to reduction in paperwork burden for facilities as well as for the ombudsman, who really were becoming overwhelmed by copies of transfer discharge notices for situations that didn't really warrant or require their further investigation. In terms of pharmacy services, CMS retained the requirement for PRN orders for psychotropic drugs to be limited to 14 days, but what they did was propose to allow PRN orders for antipsychotics as well as other psychotropic drugs to be extended beyond that 14 days as long as the physician or the prescriber's rationale is documented in the medical record. And finally, as Janet noted earlier, this change was around the infection preventionist was to allow a little more flexibility for the facility to determine what is the appropriate, the most effective amount of time for that individual or individuals that you've designated as your infection preventionist to be in the facility in order to oversee your infection control program. There are a couple significant changes that CMS proposed under the physical environment requirements. And one is that the requirements that require newly constructed, reconstructed, or newly certified facilities to accommodate no more than 2 residents in a room, and that newly constructed or newly certified facilities equip each resident room with its own bathroom, including a commode and a sink. So they took those requirements and they said, those should only apply to either newly constructed facilities or newly certified facilities that haven't previously been a long-term care facility. And the idea there really was to remove barriers to making needed upgrades to buildings or remodels, and really prohibiting folks from doing that due to the costs of making those changes. There was one other important change in this section that concerned the life safety code and the FSES scoring. That's a change that doesn't affect too many providers out there, but for those impacted by it, the impact is really huge. And that change is something we had advocated for at AHCA for quite some time, so we're really happy to see CMS propose changes there. Janet reviewed some of the changes to the compliance and ethics program that are proposed, and many of those did reflect AHCA's recommendations to CMS. On that facility assessment, CMS didn't propose too much of a change, but they did propose to revise the minimum time frame to update that assessment from annually to every 2 years. So you still need to update it when there's a significant change. That language still remains, but otherwise they've allowed a little more flexibility there. One of the changes CMS made that really was designed to hopefully help with some of the workforce issues out there is to remove that requirement that if you don't have a dietitian employed full-time, your director of food and nutrition services has to be a certified dietary manager or CDM. So instead, CMS said that in those situations, the director of food and nutrition services should have 2 or more years of experience in that position or have completed a minimum course of study in food safety. Now, this is one of those requirements that many folks who work, do trainings for certified dietary managers and work in that field have really opposed CMS's proposed change to eliminate the CDM mandatory requirement. Now, of course, the rule does not prohibit you from hiring a CDM or retaining the individual who has that certification in your facility, especially if you feel that that individual best meets your center's needs. But we supported this change because it really does allow flexibility and address some of those workforce issues out there. But given the real pushback that CMS received in some of the public comments to the rule, we believe that this could be a change that CMS may consider not finalizing given the opposition. So we'll have to see how that plays out in the final rule. And the last couple of things, Janet discussed the QAPI program requirements. And just to emphasize, this was really all about giving providers greater flexibility to tailor your programs to your center. That's the whole point of these requirements. QAPI is not a one-size-fits-all. So hopefully what we're going to see when CMS finalizes this rule is that it's a program that, yes, you have to have the required elements, but that really is going to give you the flexibility you need to tailor the program, just as Janet described she does in her center, really looking at the issues in your building and how you want to address them and prioritize them in the most effective way. As you prepare for phase 3, to add to what Janet said, even though I know we still lack the guidance for the QAPI program, I would encourage you to look at some of the existing resources out there. And in particular, I think you'll find that the existing interpretive guidelines for the QAA committee and the QAPI, the QAPI plan that you had to have in phase 2, there's actually a good amount of guidance in Appendix PP that touches on some of this, and I think that you'll find it helpful in trying to get yourself set up for the surveyors to come in on phase 3 and have those QAPI elements in place if you don't already. As I mentioned, CMS also included a few changes related to the enforcement process and some of those enforcement regulations, and those are some changes that AHCA had been advocating for, so we were happy to see those changes. And one of the ones I wanted to highlight for you, which has really been an AHCA priority, is the proposed changes to the IDR process, which included requiring the process to be completed within 60 days, which is the time frame that's required for the IIDR. and ensuring survey results are not uploaded into Nursing Home Compare until the IDR process is complete. And then for IIDR decisions, CMS proposed to put in regulation requiring that CMS provide written notification with the rationale for the reviewer's recommendation and the final decision by CMS. And this is something we think is incredibly important and common sense and should be happening in all cases. And the good news is that CMS agrees with us on this point. Now, CMS does retain the authority to overturn an IIDR decision if it doesn't agree. But with these changes, CMS would require that you receive a written rationale of that final decision, including in situations where CMS doesn't agree with the reviewer, why they didn't agree. And we think this is going to be incredibly useful and informative, hopefully to improve the quality of surveyor citations and decisions, your understanding of why CMS has made the decision it made. Even if you don't always agree, at least we'll have that information. So a couple more points about the proposed rule. Of course, AHCA developed pretty extensive and detailed comments on the rule. We submitted those in September. So we wanted to make our voice be heard. And perhaps even more importantly, AHCA members submitted hundreds of comments, probably close to 1,000, more than half of the comments that were received by CMS. And there were almost 1,700 total comments that were given to CMS on this proposed rule. And we really appreciate all of you out there who took the time to look at the template sample letters we developed or to write your own and really speak to CMS about the impact these changes would have on your center and your ability to provide quality care. So now CMS has to take all of that input from the public, from us and other stakeholders, and review those public comments and make decisions about what proposals to finalize and what to issue in the final rule. And of course, we don't know exactly what they will do. We hope and expect they will finalize many of the proposed requirements, but unfortunately, we don't yet know when. One thing we do know is that it is very unlikely to happen before November 28th, as Janet mentioned. So we're going to have to really kind of thread this needle and walk this line between those changes that were proposed but are not yet finalized. So one of the other things impacting all of this is that in the proposed rule, CMS proposed to delay implementation of some Phase 3 requirements for 1 year after the effective date of the final rule. So that has not yet been issued. So the proposed delay, although it's proposed, is not actually in effect until CMS issues that final rule. CMS smartly made the decision to include the QAPI and compliance and ethics program requirements in that delay because they were sort of significant changes. But unfortunately, we won't have that in effect on November 28th. So what does this mean? Because this is a proposed rule, as I said, the delay is also proposed. In the rule, CMS states that their rationale for the delay was to avoid unnecessary work, confusion, and burden associated with implementing requirements that would likely change in a final rule shortly thereafter. But as Janet said, in the meantime, Phase 3 does go into effect, and the reality is that CMS cannot refrain from enforcing the current regulatory requirements because to do so would in effect mean that CMS was finalizing a new regulation without completing the appropriate administrative processes. So that's why we're saying that you must continue to prepare for Phase 3 implementation, pay attention to those core requirements that Janet reviewed, and please use AHCA resources, which I will highlight in a few slides in just a moment. CMS does recognize the challenge that the lack of guidance creates for providers and surveyors as well. And they understand, and we understand, that effective implementation and oversight of the requirements really does require that guidance. So that's why we're saying be prepared to show surveyors the steps you have taken to implement the requirements as they're written. And if surveyors start digging deeper into the details of your QAPI or compliance and ethics program that really go beyond what's in that regulatory language currently, let PHCA know, let AHCA know, and we will provide that feedback to CMS because we wouldn't expect to be seeing that at this time until we have further guidance. I want to just take a moment before we turn to questions and resources, just to say a word about some of the other initiatives going on at the CMS level in Baltimore that are really influencing some of the policies and guidance that are coming from CMS currently, and some of those that we anticipate seeing more of in the coming year. So back in April, the CMS administrator released what she referred to as a 5-point strategy for nursing home safety and quality, focused on strengthening oversight and enforcement, transparency and quality, and putting patients over paperwork. So as CMS releases further policy changes and new guidance, we can expect to see them aligning them with this framework that the administrator has outlined. So for example, the new IJ guidance that we saw in Appendix Q earlier this year would fall under that category of strengthening oversight and hopefully moving toward more consistency and accuracy in IJ citations. Now we know there's still a lot of work to be done in that area. Surveyors are still learning how to implement this new guidance, and we continue to give feedback to CMS when we see IJs that do not meet that guidance. So if you have examples of that, please feel free to share them with PHCA, with AHCA, and we'll give you an inbox contact at the end, because we continue to provide feedback to CMS to make sure that guidance is implemented appropriately and consistently across the country. So the release of the proposed rule, again, falls under that Patients Over Paperwork initiative. And in terms of improving quality, CMS has said it is looking to do more with investing CMP funds in technical assistance and other quality resources. So that includes the National Partnership to Improve Dementia Care and a toolkit they released earlier this year on staff retention that maybe you have seen. And CMS continues to roll out 5-star changes, such as adding PBJ data to Nursing Home Compare as part of what it calls its transparency effort. Now, CMS framed its release of the new abuse icon on Nursing Home Compare as part of these transparency efforts. And AHCA really disagrees with how CMS rolled it out, and we're advocating for changes to the icon itself and the policies behind it so that it actually meets that purpose of transparency and directing consumers to seek additional information rather than telling them to stop and avoid, which is what we think the current icon says. So before we go and turn to questions, I want to leave you just with a few details of AHCA resources to help you with Phase 3 and beyond. All of these resources can be found on the RoP page on AHCA and CalEd, which is indicated here, little yellow arrow there. And when you land on the RoP page, you're going to see a number of different areas of Phase 3 requirements outlined. And within each topic, you'll find different resources that address those areas. So for example, under Compliance and Ethics Program, there's a 10-part webinar series, there's a toolkit, there's links to the OIG guidance, and a lot of other great information. And that's just one example. One other thing I wanted to draw your attention to that you'll find here under Phase 3 Overview Materials, there's a Phase 3 implementation video recorded by Dr. Gifford, and there are a number of RoP Phase 3 checklists, including a policies and procedures checklist. And if you remember the AHCA playbook that we rolled out when the rule was first issued, we've updated all of these documents to highlight the Phase 3 requirements so you have that information. And if you want to use that to kind of do a self-audit and make sure you've got the required elements in place, this is a great place to start. As I mentioned, here's that email address in that inbox. If you have further questions that we're not able to answer today, or if you'd like to send us any additional information or feedback, regulatory@ahca is the place to go. And we look forward to hearing feedback from you and happy to answer any questions. So I think with that, we will turn to questions, and I'll turn it back to Wendy.
Great. Thank you, Sara and Janet. That was a lot of information that you got in very quickly in 45 minutes. So if anyone does have any questions, please type them into the question pane on the right hand of your screen, and we'll take a few minutes to have Sara and Janet answer those for us. It's a lot to take in. All right, we'll give it another minute or two. No questions yet. Maybe we should have another webinar after the implementation. I'll bet there will be questions then. All right, well, I will be sending a follow-up email with Janet and Sarah's contact information. So if you do have any questions, you can reach out to them, and I will be sending a link to the handouts as well. So look for that. Please be sure to complete the survey. It is important to us and our presenters. It gives us good feedback. And I will close the webinar for now. Again, we have many more webinars coming up through the end of the year. We've got 3 more webinars coming up, so please take a look at the PHCA website and see what's coming. Next week we have a Dementia and Alzheimer's Association presentation webinar, so that'll be a good one. They have some new resources that will be coming out in the new year. And then we have a rescheduled Psychology of Change webinar that was rescheduled. We had some technical difficulties back in October, so we have that rescheduled for November 26th. And we have an update on medical marijuana in early December, and I'm working on the webinars for 2020. So please take a look. There's new information out all the time on our website, so please take a look. And again, I just want to thank Sara and Janet for presenting on this topic and their time today. Thanks, everybody. Have a great remainder to your day.